Case 27. An elderly woman presents with a fever and profuse voluminous watery diarrhea. She had been treated with clindamycin for an infection a few weeks before. Her colon sigmoidoscopy displays yellow-white plaques, as expected by the doctor, after testing her stools for the toxins. So let's take a moment and understand what is the most likely diagnosis and what could be the common causative organism. Then we will discuss detail about pathogenesis, treatment, diagnosis, and prevention. So the diagnosis here is pseudomembranous colitis, also known as antibiotic-associated diarrhea, or famously known as Clostridium difficile associated disease, or CDAD. The causative agent is Clostridium difficile. Now let us understand its pathogenesis. So it is a most common healthcare associated infection in the Western world. And there is one hypervirulent epidemic strain known as ribotype BI-NAP1-027. This is considered to be having too much virulence. What are the risk factors for causation of this disease? Prolonged hospital stays, prolonged broad spectrum antibiotics, especially those with start with C. I remember the mnemonic C5. So clindamycin has maximum propensity to cause this. Then cephalosporin and carbapenems, ciprofloxacin, and other fluoroquinolones, and coamoxicillin. It is also associated with use of gastric acid suppression like antacid and proton pump inhibitors. Suppression of normal flora due to any other reason may also lead to this disease. Elderly age, especially more than 65 years of age, is susceptible. Immunosuppression and use of electronic rectal thermometer is associated with CDAD. So what is the pathogenesis? So once you ingest the spore, it will colonize the colon and they act as a normal flora of GI tract. And antibiotic treatment disrupts other normal flora, but Clostridium difficile survives by generating spores, and spores germinate following antibiotic treatment completion. They grow quickly because of absence of competing normal flora, and they release two toxins, toxin A and toxin B. Toxin A is basically enterotoxin. It alters the fluid output and results in watery diarrhea. Sometimes it may cause hypoalbuminemia. Toxin B, on the other hand, is a cytotoxin, and it is cytotoxic to epithelial cells of intestine. It glycosylate the GTP binding proteins that regulates the cellular actin cytoskeleton and disrupt the cytoskeleton, which will lead to loss of cell shape, adherence, and disruption of epithelial cell barrier. And these may lead to pseudomembrane formation, resulting in either diarrhea or dysentery, which may also lead to toxic megacolon and bowel perforation as a complication. Infants usually have asymptomatic infection because they do not have receptors for these toxins. We develop immune response to this, but if immunoglobulin to this toxin A is inadequate, we develop disease. If we have adequate immunoglobulin, the person may act as a carrier. So if we talk about clinical features, it usually starts 5 to 10 days after starting the broad spectrum antibiotics. Watery diarrhea is the most common manifestation, followed by dysentery, abdominal pain, and fever. Leukocytosis is a prominent feature, and on colonoscopy, you will see that white yellow pseudomembrane is seen. Pseudomembrane is basically necrotic WBC, fibrin, mucus, and cell debris. And this is seen over entire colon mucosa. 90% of them, they will respond to treatment, and relapses 15 to 30%. Ninety percent of population who is affected with CDAD, they respond to treatment, but we have seen that relapse happens in 15 to 30% of cases. There are two main complications. One is bowel perforation, and second is toxic megacolon, in which there is more than 6 centimeter diameter with no obstruction. Mortality resulting from toxic nitrocolon is up to 64%. Now, coming to the investigation portion. So, toxin demonstration in stool is more meaningful, and here 2 or 3 stage testing is recommended. So, you have to do either glutamate dehydrogenase assay in stool or PCR for gene detection. Either you do one or both of them. You have to confirm their result with subsequent enzyme immunoassay for toxin A or B detection in stool. If both the results are concordant, then it confirms the active infection. But if discordant results are there, that means if earlier ones are positive, but the EIA is negative, then it may indicate colonization. Now, GDH is present in both toxigenic and non-toxigenic strain, but PCR may detect specific genes coding for toxin A, that is TCD-A gene, toxin B, that is TCD-B gene, and triose phosphate isomerase gene, that is TPI in stool. Enzyme immunoassay for toxin A and B indicates presence of toxigenic strains only. That's why it is more specific. Because gene, obviously you detect, but it is not necessary that all genes may express. That's why they have uh, more emphasized on phenotypic detection using enzyme immunoassay as confirmatory. If you do colonoscopy, it is highly specific if pseudomembranes are seen, but sensitivity is low. And stool culture or isolation is difficult, hence the name difficile. Uh, Anaerobic culture is required at 37 degrees centigrade for 24 to 48 hours incubation. And two mediums which are commonly used are cefoxitin cycloserine fructose agar and cefoxitin cycloserine egg yolk agar. They are sensitive and specific, but not enough to establish the infection, as bacteria is common colonizer of GID. That's why toxin demonstration is more significant than culture. Cell culture cytotoxin neutralization assay is highly specific but not sensitive. Coming to the treatment portion. So first of all, whatever is causing the disease, you have to stop that. So stop the proton pump inhibitors, withdraw the causative broad spectrum antibiotic like Clindamycin, and if antibiotics are necessary to give, then switch to the antibiotic which usually do not normally predispose to CDAD. That means safe antibiotics like piperacillin, tazobactam, paroral doxycycline, IV benzyl penicillin, IV vancomycin, IV teicoplanin, IV temocillin, and IV gentamicin. So, what are the therapeutic options we have to treat this condition? So, oral vancomycin, not IV, oral vancomycin. It is not absorbed orally, so it remains in intestinal lumen and act on this intestinal bacteria. If you give IV, it will never reach to gut lumen. That's why never give IV vancomycin. Oral fidaxomicin is like a non-absorbable macrocyclic antibiotic. It has lower recurrence rate if it is used as initial therapy compared to vancomycin. It is not effective for the ribotype 27. Otherwise, it is a preferred antibiotic if antibiotic therapy cannot be stopped in the patient. Oral metronidazole. It is inferior than vancomycin and fidaxomicin. And as a last resort, you can even use fecal microbiota transplant or FMT, which involves replacement of colonic contents with stool containing normal flora from a donor. But stigmatization limits its use. The new regents like rifamycin and IV immunoglobulin to toxin A can also be tried. So, what is the algorithm for CDAD management? So, as per my knowledge and whatever the literature so far says, I have prepared this algorithm. It may change in future with more evidences and more studies, but till date, I think this is what every guideline in summary says. So, if you have to manage Clostridium difficile. First, decide whether it is a first episode or it is a relapsed condition. If it is first episode, keep in mind that you have to give 10 to 14 days treatment. So, if condition is mild to moderate, that means fever is less than 38, WBC count is less than 15 into 10 raised to 9 per liter, serum creatinine is less than 50% of baseline, then you can consider it is mild to moderate first episode. So, per oral vancomycin or fidaxomicin can be given for 10 days. it is more preferable than perol or metronidazole. If it is severe condition, fever more than 38, WBC count more than 15 into 10 raised to 9 per liter, and serum creatinine in more than 50% of baseline, or there is evidence of colitis, then give peroral vancomycin. If it is not responding and there is no risk factor for recurrence, then in such non-responding severe cases, you can give high-dose vancomycin orally along with IV metronidazole. If there are risk factor for recurrence or person is elderly, then you should use peroral fidaxomicin. In case of severe, complicated, life-threatening cases, then you should give vancomycin in high dose through nasogastric tube as well as per rectally, and also give IV metronidazole. If still not responding, then surgical evaluation and imaging to diagnose the megacolon, and person may require subtotal colectomy and ileostomy. Despite the best treatment, the relapse rate is 15 to 30%. So if a person is suffering from second episode, that means first relapse or recurrence, then fidaxomicin is preferable than vancomycin. If it is third episode, that is second relapse and onwards, then again fidaxomicin is the choice. We can alternately give vancomycin. But not only fidaxomicin, followed by you have to also give vancomycin tapering dose over 2 to 8 weeks, followed by rifampicin or FMT. If multiple recurrences are there, then fecal microbiota transplant is our last resort. Hypervirulent epidemic strain like ribotype BI NAP 027 or ribotype 27, then fidaxomicin is always preferable. So prevention, it is a major cause of healthcare associated diarrhea, and there is a protocol known as SITE: suspect, isolate, gloves and gown, hand hygiene, and taste tool. So S stands for suspect. You have to stop all the broad spectrum antibiotic, PPIs, antacid. That is stewardship. Surgical review if needed, and sodium hypochlorite disinfection of surfaces and feces. I stands for isolate within 2 hours until 48 hours post passing forms tool, and G stands for gloves and aprons. H stands for hand wash. No alcohol, rub or gel, as they have no effect on spores. Taste tool sample for toxin. The future preventive measure could be use of some enzymes like riboxamase, which is like a class A beta lactamase enzyme, which will hydrolyze penicillins and third generation cephalosporin, and it can mop up any IV penicillin or cephalosporin that spills over into the gut. So that's how you can prevent the disruption of normal gut flora while still allowing systemic activity of the beta lactam antibiotics. So this may reduce the risk of CDAD and selective pressure driving antibiotic resistance. I think in future more and more such enzymes will come into the market. Thank you very much.